All right. Give it up one more time for Terry Vick. Incredible. And we are fortunate to bring him right back up as we segue into our next discussion. It's going to be the Cancer Plenary Panel, and this is going to be moderated by Kathleen Schmeller. And you had the pleasure of hearing from Terry. He will join the panelists. And the remaining panelists, their names and affiliations will be conveniently provided for you right here on the teleprompters. And so please join me in welcoming Dr. Kathleen Schmeller and her team.
Good morning, everyone. Thank you so much for joining our panel on using ECHO for cancer. My name is Kathleen Schmeller. I'm a gynecologic oncologist at MD Anderson Cancer Center in Houston, Texas. We started using ECHO in 2014. Our first ECHO was for cervical cancer prevention in Texas. But since that time, we now have 23 ECHOs that span from cancer prevention, cancer treatment, policy, public health, palliative care, survivorship, and we, since 2017, have been a super hub for oncology. So our team is really honored to be here at this conference, and I'm very happy to be chairing this panel with people from literally all over the world. Just a little bit about the Cancer ECHO movement. The first Cancer ECHO was launched for breast cancer at the University of Chicago in 2012. And since then, there are over 175 ECHO hubs that have launched programs within the cancer continuum of care, with over 560 separate ECHO programs. These ECHO programs span approximately 27 countries. So a big welcome to our panelists today. I'll be asking questions of each of the panelists. So Daniel, maybe we'll start with you. Can you tell us what motivated you to start ECHO in your institution?
Thank you very much, Kathleen, and good morning, everyone. Kimberley Hospital in South Africa was the first center to launch Cancer ECHO in Africa. And what motivated us to do so was the fact that Sub-Saharan Africa, and including South Africa, has huge disparities and inequities in cancer care. The Northern Cape province of South Africa, where I work, is the largest province in South Africa, and it has fewer resources for cancer care. There is a high incidence of mesothelioma and lung cancer in the province due to the previous indiscriminate mining of asbestos without proper protection of the miners and the environment. Even though asbestos mining has been banned, asbestos dumps remain in villages and near villages and schools, leading to continuous exposure of the communities to asbestos fibers. And this has led to high incidence of lung cancer and mesothelioma. Unfortunately, most of these cancers are diagnosed very late due to the fact that there's lack of awareness about these diseases, and also the fact that there is misdiagnosis of lung cancer and mesothelioma as pulmonary tuberculosis. So we needed an innovative model to address these problems, and that is why we launched ECHO. One of the reasons that also motivated me to start using the ECHO model was the fact that we needed to help Lesotho. Lesotho is a small country close to South Africa, and most of the patients who were diagnosed with cancers in Lesotho who needed chemotherapy were flown all the way to India for chemotherapy. And therefore, we wanted to use this ECHO model to assist them set up a chemotherapy unit so that the patients diagnosed with cancer who needed chemotherapy could be treated there. Thank you very much, Kathleen.
Thank you. Maybe just while we're on the subject, Daniel, could you tell us some unique problems or challenges that you've had?
As I alluded to earlier on, the unique challenge, especially in my province, was the fact that it was a very large province. Most of the patients had to travel very, very long distances to the cancer center to get their treatment. And therefore, we needed to use this ECHO model to set up satellite treatment centers in the district hospital so that the patients didn't have to travel very long distances to come and get their treatment. And as I also said, people in Lesotho who were diagnosed with cancer had to travel very long distances to be flown to India for chemotherapy treatment. Patients diagnosed with breast cancer who needed maybe 1 hour chemotherapy treatment had to be flown all the way to India. So we had to use the ECHO model to address this disparity and unique problems. Thank you.
Let's turn now to Nepal with Dr. Jitendra. Jitendra, can you tell us what prompted you to implement the ECHO model for cancer prevention in Nepal?
Thank you, Professor Kathleen. Good morning, everyone. Regarding ECHO program, we started that back in 2019 as a part of International Gynae Cancer Society Tumor Board meeting. Nepal does not have organized gynae oncology program and needed such program and faculties and mentors. So as a part of monthly ECHO tumor board, our fellows, gynae oncology fellows, would prepare the difficult and dilemma cases and present among national and international faculties who would then contribute and encourage them to find a proper management and solution for the dilemma cases. So this has kind of helped in fellows in their training and also has given more of confidence and competency to the local faculties in serving such gynae cancer cases in the country. So ECHO, tumor board ECHO has been very effective in gynecologic oncology fellowship, as well as upgrading our services and our program. And in addition to that, cervical cancer in Nepal is very common with high incidence and mortality. And it is due to difficult geography that Nepal has. In some of the communities, nearest motorable road is around 2 to 4 days walk. And this has kind of contributed to poor screening uptake. And more than that, we have less of human resources and logistic. So that often kinds of leaves behind the detected positive pre-invasive cases go untreated. So to solve this problem, Cancer Care Nepal, along with MD Anderson team, started cervical cancer prevention program in Nepal, which had incorporated ECHO. And it has been very effective because we have participants from remote places sharing, discussing their cases where national and international faculties contribute to possible solutions. And it has been very effective. So ECHO program for Nepal has contributed to cancer prevention, cancer education, and of course, upgrading our treatment facilities as well. Thank you.
Thank you, Jitendra. And I will say our team has been very inspired by Jitendra and his team and all their work, first with cervical cancer treatment or all gynecologic cancer treatments through the IGCS, but now expanding the ECHOs to cervical cancer prevention. What Jitendra left out is that he launched much of that program during the COVID-19 pandemic and was really successful in being able to do it despite all the challenges.
And we're very thankful to you and your team, Professor Kathleen.
And to the Prevent Cancer Foundation for funding the project. So thank you to Bo and team for that. Terry, thank you so much for your very inspiring presentation. Can you tell us a little more about why did you and your team choose ECHO for your work to create awareness of cancer and to improve care?
Sure, thanks for that question. So not only do I do pediatric oncology, but part of my job as sort of the North American field director for oncology in AMPATH, I've been tasked with supporting the breast cancer program, the multiple myeloma program, sickle cell, and palliative care. So at the start of the pandemic, it became obvious that our model of doing outreach programs to reach our community of learners, where we would go for a day or two and try to train local healthcare workers on what to do for breast and cervical cancer screening or myeloma awareness, that model would need to shift, and ECHO therefore was a nice segue into that. So we'd already started our pediatric ECHO, and being able to leverage all of the infrastructure of AMPATH with our telemedicine rooms, our outreach to communities, we could enlist all of our partners. In each of those programs, they all had different sets of partners. So it was when we couldn't travel, we could still reach them through WhatsApp and through launch of ECHO programs, which supported the continued training and awareness for all of those diseases in Western Kenya. So it really has kind of a fortunate advantage for us at that moment in time.
Great, thank you, Terry. Dr. Haradini from Indonesia. Can you please tell us what was the state of cancer burden and healthcare services in Indonesia when you initially joined the ECHO program? And what notable improvements have been achieved so far through your involvement in the program?
Thank you, Kathleen. Thank you all. Good morning. Well, Indonesia have this, it's called BPJS program. It's a university health, universal health program for Indonesian people. But in 2016, we realized that many patients came to tertiary hospital in the late stage. So we made the implementation of this referral system, but that doesn't, but still have numbers of patients came to a severe illness. And then we joined ECHO. Later, it's not only a referral system, but telementoring is teach us that patient, it can help from far. I mean, the introduction of telementoring through ECHO program is a turning point, especially for cancer patient. And ECHO is fosters stronger connection between tertiary hospital to hospital and low facilities hospital, and facilitating more effective communication for referrals. So nowadays we witnesses that many cancer patients come to early phase, so we can help them. Okay.
Great, thank you. And I'll just give a shout out to the team at Darmais National Cancer Center. They just launched their breast cancer ECHO last week and had 103 participants for the first session. It was really, really impressive.
Thank you.
And not just from Jakarta, from many areas of Indonesia. Laura, the American Cancer Society is somewhat unique as a large nonprofit organization. Can you tell us more about how the American Cancer Society and what motivated you and your team to start using ECHO?
Yeah, sure. Thanks, Kathleen. It's so great to be here with you all today. You know, I've been a part of ECHO and the ECHO movement for quite some time now. And at ACS, you know, we exist as a large nonprofit based in the US because the cancer burden is really unacceptably high for everybody. You know, within the work that we do in patient support at ACS, we're really working to help solve complex cancer problems that impact so many of us, patients, families, caregivers, and then all the people in our networks that, you know, we're all unfortunately likely to be impacted in one way or another by cancer in our lifetime. So, you know, we have this vision statement that I really love, and it says that we want to end cancer as we know it for everyone. And that is a nice vision statement, but it really guides the work that we do. And with the use of ECHO, it really was just a natural fit. So we became an ECHO hub and partner in 2017. And since then, we've launched 46 unique ECHOs and had over 2,600 learners participate in our ECHOs, really across the cancer continuum, from prevention, things like tobacco cessation, screening, HPV vaccination, to using lung cancer biomarkers to help guide treatment and help treatment teams understand how to do that, to our latest ECHO this year that we've launched to help meet the unique needs of Black and African American caregivers, knowing that caregivers are also a really important part impacted by cancer, and what we can do to help cancer care teams address those needs. So it's been quite a journey, and we're really, I would say, just getting started. Our ECHO team is here, and we're really happy and proud of the work we've done, and really looking forward to so much more in the future.
Thank you, Laura. I'd like to pivot to talk a little bit about some of the challenges. Terry, maybe we can start with you. What are the challenges involved in getting participants to join ECHOs in Kenya?
Well, I think all of our programs have unique challenges. I think one of the things that we wrestle with, depending on how involved an international partner is with a particular ECHO, trying to find the right time zone to have our ECHOs. So we'll have the pediatric oncology ECHO and the sickle cell ECHO at 8 a.m. Kenya time, which then for me and Tyler is at 1 a.m. or midnight. So we get to join twice a month for challenging ECHO sessions then. Other ECHOs that might be more dependent on North American partners or European partners could have an afternoon ECHO, and the myeloma team has decided that their learners want to be not interrupted during the day, and so they have chosen a 7 p.m. time to have their ECHOs. So I think, as you'd expect, knowing who your learners are and what they're interested in and how they can function best, adapting a program to those learning environments makes a big difference to improve your participation. And I think that's a challenge for us all. I think the other challenge that is a universal challenge that I would expect everyone would agree is that getting people to return a survey tool to give a input on how they like the session is also a challenge, and we have not figured out how to solve that one yet. Although Sam Mbuye may give his ideas at his session this afternoon with the Kenya panel that we have. So thanks.
Thank you. And Dr. Haradini, could you elaborate on the key challenges you have encountered while implementing the ECHO program in Indonesia?
Well, the challenge is Indonesia have this vast archipelago, so it making it difficult to reach tertiary, to reach remote areas, and in some regions, reaching for the tertiary healthcare centers is very difficult and costly, of course. And this telemonitoring is good solution that remote areas have a necessary remote infrastructure. However, complications arise when facilities are limited, necessitating patients to basically travel for treatment. So Furthermore, telementoring demands dedicated time and luxury not all physicians can afford.
Great, thank you. I know one of the challenges we have had is having people bring cases. I think everyone in the room has experienced that. I will tell you from Indonesia, that never seems to be a problem. They're very, very forthcoming with many, many cases. Let's talk a little bit about impact. Daniel, what has been the impact of the ECHO model in your community institutions so far, or your achievements to date?
Thank you very much, Kathleen. Through the power of ECHO, we have managed to form an advocacy group which has engaged the government to rehabilitate the asbestos mine dams. So at least the problem is being solved. Some of the mine dams are being rehabilitated. Secondly, we have managed to train a lot of community healthcare workers who are assisting in community awareness and patient navigation, and it has led to improved referral system. So we are now seeing the patients early instead of seeing the patients coming with late diagnosis. The other impact that that has been made is the fact that we have managed to train doctors, nurses, social workers, clinical psychologists in the rural areas. So there is retention of those healthcare workers, trained healthcare workers, to help improve giving cancer care. We've also launched palliative care program, palliative care ECHO, and the patients are able to receive palliative care close to their communities. We know that in Africa, palliative care forms a very, very important integral part of cancer treatment. The reason is that most patients are diagnosed with late stages of cancer in Africa, and therefore there's a need for palliative care. In the past, most people thought that palliative care is a care that is given only at the end of, end of life. But through the ECHO, we have managed to teach people that palliative care begins at diagnosis and not at the end of life. So we are able to, our healthcare workers are able to give effective palliative care. And as I said, we have also managed to assist Lesotho to give chemotherapy to patients in Lesotho and no more fly the patients to India for treatment. And also in the Northern Cape province, the patients no longer have to travel long distances. In fact, in the past, some patients were traveling about 900 kilometers, 500 kilometers to come to Kimberley for chemotherapy treatment. And they no longer have to travel for such long distances. They are able to receive treatment closer to their communities in the district hospitals due to our ECHO program. And during COVID-19, we used the ECHO model quite effectively to assist giving of cancer care in our province. Thank you very much.
Congratulations, it's truly a model. Jitendra, can you tell us how the participants and/or patients in Nepal have benefited from your ECHO programs?
Yes, as I mentioned earlier, like we are using ECHO in two programs. One is IGCS Gyne-Oncology Fellowship Program, where we have had 2 graduates and 2 are in training. And the graduates, graduated fellows, now they are in active service. So they are catering to their services to more of gyne cancer patients, reaching out more of cancer patients. So that has been a remarkable observation. And the other thing, with the ECHO, like multidisciplinary team approach has been established. So I think that has been a big strength in our service, where we recognize the contribution of various specialists, from pathologists, radiologists, and even nurses and palliative care workers, apart from active oncologists. So these have been the strengths. And regarding cervical cancer prevention, which is another important part, like we have had cases being shared from remote places saying that, okay, we've identified some of the cases and we have offered them treatment. And this has kind of become a change and positive chain for other centers and other health workers to believe and become more confident in providing the services. And so we are happy that this has given positive impact in remote places where cervical cancer screening was not, did not exist. Now the program is there, and even the treatment facility is there. So these have been some of the gratifying changes that we have observed, and this is being shared in monthly echo. So this has been positive impacts.
Great, thank you, Jitendra. And I would just say that I think that ECHO has been so important to really teach and for different groups in different countries to know more about multidisciplinary care, cancer care, which is so important. And as Jitendra mentioned, the IGCS, or the International Gynecologic Cancer Society, has a global fellowship in gynecologic cancer for regions of the world that don't have formal training in GYN oncology. And tomorrow we'll be having a session specifically about that program, but the cornerstone of that program are all the monthly echoes. There are more than 20 programs around the world now where fellows are being trained in their home countries, but ECHO has been such an important part of that and in having these multidisciplinary tumor boards. So stay tuned for tomorrow to learn more about that. Terry, could you tell us what methods you've been able to use to judge the impact of your ECHO programs?
Sure. I think that's one of the areas where we focus on beyond the just satisfaction of learners. You know, I think one of the things we're trying to do is extend our reach, get to more counties, reach more learners, and our outreach programs that continue now that the pandemic has eased. We are continuing to go out to counties and recruit more and more people to join our ECHOs. And I think showing that the trends of participants at our sessions continue to increase, I think that's a major way that we've used to judge impact of our program. And I think the other major way that we are showing impact is definitely in the pediatric oncology realm, as well as in the myeloma realm, just the numbers of patients that are being diagnosed and referred for care. We're fortunate that even though cancer seems to be an overwhelming burden, it still is small enough numbers that you can track locally to say, are you having an impact? Are you showing that you're getting more and more kids into care or adults into care? And I think Tyler Severance will be talking about that impact in a session later this morning, where you know it's very clear that counties that participate in our ECHOs increase the numbers of patients that get referred. So it's a very solid, striking finding. I think the numbers in the myeloma program are similar, although they are a year or so behind us in their evaluations. And then the breast and cervical cancer program, that program is fairly mature in Kenya in the sense of certain counties and sub-county hospitals where care is being given. And so they have a little bit more of a challenge, but they're, again, trying to extend their reach and through the AMPATH universal health coverage and trying to trying to incorporate universal screening for multiple conditions, trying to build breast and cervical cancer screening into that healthcare plan, I think is showing good impact with ECHO from there. So there are a lot of different ways that you can get good data that shows that your program really is having an impact. So I encourage programs to think about that as they're trying to implement new ECHOs. Thanks.
Great. And Terry, could you just tell us as well how you support ECHO financially for the sustainability of these programs?
I'll say two things. One is, for as big a program as it is, ECHO is relatively cheap. You know, we run all our ECHOs on a fairly limited budget. We have philanthropic funds in various areas that support care programs in breast and cervical cancer and myeloma and pediatric oncology. And so all we really need to do, because our hub team members are care providers within our hospital, they have a vested interest in, so we don't have to recruit a lot of outside experts. The technology is already in place. We need a little bit of an incentive by offering CPD or continuing medical education points to learners, and that it really is just the time of the coordinator to gather up a case and put it together for a session, and it really is only a few hours, once or twice a month, depending on how you do it. And so I think we have been able to sustain all of our ECHOs, even when one source of funds might dry up, that were committed directly to ECHO, because the program, once it's in place, it really is fairly self-sustaining. And so I think that for us has not really been a big challenge. Sure, we'd like to have a giant super hub and have multiple coordinators and facilitators and administrators and people to gather data, but that's a luxury. You don't need that, but if you have it, you use it. So we keep looking for grants to do that, but you really don't need it to have a successful ECHO. Thanks.
Thanks, Terry. Dr. Haradini, can you tell us, in your opinion, what aspects of the ECHO program in Indonesia could be improved to build more impact on cancer management and care?
Yes, well, the crucial aspect is of ECHO is include didactic session and sharing cases or experiences. This contribute to the proper execution for prevention until rehabilitation management protocols. Well, however, the availability of adequate facilities remains a challenge. So, therefore, it will be very beneficial if ECHO could facilitate the process, such referrals for pathology and molecular testing from remote areas to tertiary healthcare centers.
You have quite the challenge in Indonesia with with all the islands. Laura, could you tell us what unique problems you were trying to address when you first started ECHO at your institution?
Yeah, sure. I'm happy to share a little bit about that. I wouldn't say that we set out to solve just one problem, except the big problem called cancer, and really, looked at using ECHO to help solve problems across the continuum of cancer care. When we, after we became an ECHO hub in 2017, one of our first ECHO sessions was around lung cancer treatment, so that was fairly clinical, and then followed soon after by an ECHO that was focused on tobacco cessation for residents of public housing that was supported by Robert Wood Johnson Foundation effort in line with the smoke-free public housing rule. And that one was really fun and unique and practical, meaning these were residents who were living in public housing. They know how to rule they couldn't smoke in their housing. That could be a cause for eviction, which obviously has all other health concerns. And so that one we really worked with the community health centers that are taking care of the patients who lived there, and worked on both the practical parts of clinically, how do you help do tobacco cessation better and really meet patients where they are, as well as the systems change that needed to happen to help support the housing complexes with implementing the rule and while also doing that in kind of a patient-centered way. So that was a really kind of a blended model, I would say, of kind of clinical as well as systems change. Then we've also done some work. We have ACS does have a global footprint, as you may know, and we use ECHO to support our SOURCE program, which is a program that works to strengthen civil service organizations that are focused on helping with cancer in their communities. And there was a session yesterday that my team member did, and so that you can look at that SOURCE program at ACS, and we had some really nice success of using that for strengthening civil service organizations too. So I would say we really kind of have tried to use ECHO to address problems across the continuum. We see there's value in both the very kind of like clinical parts of things as well as the systems change, and it really is about building that learning network and getting to the best practice sharing. And I think one of the things that I love about ECHO is it's really practical. The clinicians who are participating and the learners, the teams are really getting practical tips about and learning from each other as well as the experts about what to do with their like real life problems facing them. I have this like memory of the Smoke-Free Public Housing ECHO, which was like years ago now, and my memory, I will tell you, is not that good. But it has stuck with me. I was a facilitator for the sessions, and there was just some really nice practical things about how to help motivate patients when they're in that kind of pre-contemplative to contemplative phase of quitting tobacco, and figuring out what are their motivating factors. And one of our faculty members just shared about, you can find the unique motivating factor for your individual patient. And this one case was about a patient who had a dog that was really special in their life. And so they used that to help motivate the patient about like how the secondhand smoke was impacting the dog. And this patient who had smoked for like 30 years quit smoking and stayed quit through the duration of the ECHO. So I'm hoping she has still stayed quit. But I thought that was such a nice, really practical solution that clinician could go back and help his patient with like the next day. And that's really such a cool part of what we get to do with ECHO.
That's a fantastic story. Could you tell us maybe a little bit more about, I'm very interested in your caregiver ECHO. Could you tell us a little bit more about that?
I can, yeah, for sure. So thank you. So that ECHO is currently in process. We are maybe a little bit more than halfway through. Our team who leads that ECHO is here with us. We'll have more to share maybe at the next MetaECHO conference as we finish up the sessions and do an evaluation that is in progress. But the goal of that ECHO is really to help address the unique needs of Black and African American caregivers in cancer care. So we know that there's issues with implicit bias and systemic racism that really are far too common in our healthcare settings, as well as the mistrust that happens between families and their clinical care teams. So this ECHO is really designed to help address all of those issues. We've been able to, it's been remarkable to see the interest. We've recruited, I think, 13 systems, hospitals, cancer teams to participate. The average attendance at each of the monthly sessions has been around 60 or 62 learners, and that's been very consistent. And again, like you, we often have the challenge of trying to motivate people to bring cases, but this one has not been like that. So this one has been like people are really motivated and energized and looking for help with these really challenging problems around how to help meet the needs of Black and African American caregivers. So we're excited about that. It's been maybe it's one of the first ECHOs around caregiving. But maybe if you are doing caregiving ECHOs, let me know. I'd love to talk with you. I think there's just so much to do to help support caregivers in the role that they play in cancer care.
Thank you. Yes, when I first heard about it, I now think about it all the time when taking care of my patients, that we really have neglected the caregivers in all the ECHOs that we have built.
Yeah, let me say one more thing on that real quick. So all of the sessions are ECHO. We have an ECHO website, echo.cancer.org. So if you'd like to look at the sessions or the resources shared in each of the sessions, please check that out.
Great. Thank you so much, Laura. I just want to come back to something Terry said about the funding. One of the things I learned very early on from Sanjeev is that we should not think of ECHO as being free. It does take a lot of people's time, and I think most of us who are involved with ECHO are very practical people, as Laura mentioned, and are not always thinking about how much time it takes, and we're always sort of putting things together on a shoestring. But I think it's really important. during this conference, and I've already learned a lot just in the last 24 hours from people who are getting pretty significant funding for ECHOs. So I think that's a really important thing we need to think about in the cancer space. I know we talked earlier about the Prevent Cancer Foundation funding a lot of this work, both for us at MD Anderson and Jitendra's team in Nepal and Robert Wood Johnson and the NCI. So I think there's a lot of opportunity for us to really grow our programs and get funding for them. I don't know if anyone else has any thoughts on the funding piece.
Yeah, I can share just a little bit. Maybe others can think while I talk here for a second. I think it's so important, Kathleen. The funding, it's a challenge, right? But it's important, and it does take a lot of time. Our ECHO team at ACS, we've resourced more so we can do more ECHOs, and knowing that it's that there's a lot of administrative and logistical coordination and recruitment of both the sites and the learners, as well as the expert faculty to join us, as well as the evaluation efforts. So it can be done very inexpensively, but it can also be done better when we have some resources. We've had some really great success when we tell people about ECHO and what it does and the power of being able to democratize knowledge and really make a change. We have found a lot of funders really interested, which includes industry funders, which I think has been a unique part of things. The foundation grants and all of that are so helpful. We really appreciate that. But there's also, I think, a part of industry that maybe we can tap into more.
Great suggestion. Jitendra?
And I agree with Professor Kathleen that MetaECHO has been supported, but the concern of sustainability has always been there, because such a very needy program has started. We want it to continue and expand, and that has been our concern. And regarding difficulty or limitation of ECHO, I agree with Dr. Terry regarding time zone, which has been a bit of a problem, finding the participants and international mentors participate at comfortable time. Another factor locally has been economics as well, because in country like Nepal, the network is often a problem, and in remote places, the services is quite expensive, and that has been their feedback and concern regarding participation, because telecommunication services, internet services in Nepal till date is a bit expensive for rural people and health professionals.
Thank you. Any other comments on financing?
Yes, I just want to comment on financing or funding ECHO programs, especially for African countries. I think if you ask most of the colleagues from Africa, what are your two main problems of running ECHO, they will mention one, lack of resources, and two, lack of funding. Okay, third one will be connectivity issues. In my opinion, I think that we should market this project ECHO to our governments. We should not only rely on external funding, because quite often we start our ECHO programs or other projects from funding from the US or European countries. Once that funding is finished, the programs and projects fall flat. This is because we do not market the programs to our governments. So what we did in the Northern Cape was that we involved the government. The funding of our project was initially from Bristol Myers Squibb Foundation, but it was a 3-year project. So before the project ended, we involved our local government, and now the government is funding the project. So I'm advising other colleagues from Africa to make sure that we sell our projects to our governments so that they can fund the projects. Thank you.
Great, thank you very much. As we wrap up, are there any other comments anyone would like to make?
Yeah, I'll just clarify on funding. I think although we get by on a shoestring, every time we apply for a grant, we do include ECHO as part of the cost, so that and I think like in South Africa, the Ministry of Health within Kenya is recognizing the impact of Project ECHO and is making strides to figure out how to support those efforts, especially because it works across all of Kenya quite seamlessly. I think that is a luxury that we have in Kenya as well. The technology for internet connectivity is honestly quite good. And so most people in the counties, at least in the bigger cities, have good access to coverage, and that really has not been an issue for us as well.
I think Daniel brings up a really good point too of the amount of money we can save the governments too, right? By patients not needing to travel to India for their care, or just really decreasing the cost of training or training more people. Diagnosing cervical cancer, in pre-invasive phases is much cheaper to treat than advanced cancer. So we definitely all together can do a much better job of that. Any other points anybody would like to make?
I was just gonna, I was just thinking about this. Has been pretty remarkable to see the, the true global panel here, and the burden of cancer really is concerning and unacceptably high for so many countries, maybe all of our countries. And ECHO just is a powerful tool, and I think in the cancer space we have, much work to do together, and many patients and families to make a difference for, and it's just like the potential is so great and lots of opportunities to make a big difference.
Yeah, I couldn't agree more. I've been practicing oncology for almost 20 years now, and I would say that Project ECHO, I say this all the time, is probably one of the simplest yet most impactful programs that I've been part of, and in all the different things I've done related to cancer care. So I would completely agree, and it's really inspiring to be here with so many people. Just a few closing points. There are over 35 cancer and palliative care related presentations and discussions at this conference, including several by today's panelists that you heard about. So you can scan the QR code that's on the screen to preview other Cancer ECHO presentations. And then also today, the Cancer ECHO Collaborative Lunch will be at 12 p.m. So if you're active in the space or if you'd like to learn more, we encourage you to join. Dr. Haradini from Indonesia and her colleagues from the Darmais National Cancer Center will share a bit more about their work and their strategy to scale ECHO, not just in Indonesia, but in the region in general. And so all are welcome, but kindly RSVP using the link provided in the Cancer ECHO preview. So with that, I'd like to thank all our panelists for joining today and for all of you for coming. So thank you so much.
Thank you.